Well, good afternoon, everyone, and thank you to the organisers for asking me to be a discussant. I had a few thoughts before I sat down, but I've had to change them all, Cliff, because you made me think, and that's not a good thing. But I'd like to thank the Safety and Quality Commission for its sponsorship. Clearly, there's been a loosening of the purse strings since I left. And also to Cliff, I asked him what was he going to talk about, because I had no idea. And he sort of went to the topic. And so I said, not planes and not trains, Cliff, but automobiles. So and he almost kept that going. So well done. And I'd like to thank you for that. What I'd also like to do is just to quickly extend why I think Cliff's analogy of traffic systems as a comparison and not planes and those other things he mentioned is why it's so useful. And these are thoughts that were provided some time ago by Kathy Balding, who was previous manager of the Victorian Quality Council, now runs consultancy Quality Works, and I have no shares in her organisation. I just embarrass her every time I say that. But she talked about traffic systems as a useful comparison for healthcare, and because both are high-risk, highly public systems and have constant change which requires quick and appropriate response. That gels with me. Both have policing functions built in and to varying effect. Both depend on the behaviour and decisions of independent, fallible human beings acting alone and interacting with each other for safety. And the final point is that we expect to be safe in both environments, but we have a tolerance for risk. We have a tolerance for unsafe practice and the consequences until there's a catastrophe. And that resonates, certainly not with the way you drive, I'm sure, or the way I might drive. But I think that, for me, is why that sticks in my head, and I thank you, Cliff, for using that analogy, which I think is extremely refreshing. By the way, in relation to driving, Cliff put up some slides there that could be categorised as busy. Those of you that couldn't read the slides, please hand in your driver's licence now, because that was the intent. The other point he spoke about is speed and how we slow our speed, coming up to a speed camera and so on. Have any of you noticed, certainly in Canberra I've picked up, they're now producing average speed processors, speed cameras. So you start, wherever it is, and a few kilometres down the track, they've recorded your average speed. Now, I don't know if they can or they can't, but me and a whole lot of other drivers believe them, particularly on this particular hill in Canberra going to Woden. And that just is a cunning plot to slow us down, but it's a forcing function. And it's a regulatory approach which makes sense. Cliff spent a bit of time talking about the hand hygiene and the 5 moments of hand hygiene. He mentioned about having data and about the importance of knowing how you're performing. Ian Baumer this morning spoke about doctors as self-assessors and how they're not particularly good at that. There's an excellent paper which I referred to yesterday in an evidence-based medicine talk just here in Melbourne, where doctors reported their own performance on hand hygiene. They provided their own assessment, and it was 73% was the average. Unbeknown to them, they were having discrete observations, so they didn't know someone was checking them out. And in fact, what they were doing was hand hygiene 10% of the time. So we need to be able to not believe our own publicity. Cliff mentioned how the 70% of the 5 moments is perhaps not good enough. It ought to be 100%. What evidence has shown is if you do achieve 70% of the 5 moments, and that's pretty comprehensive, you will get a maximum reduction of Staph aureus bloodstream infection. I had a personal example last week. My wife was in hospital. I spent a fair bit of time with her. Not in Canberra, won't say where it was. Some of you that know me will work out the city. And I observed the hand hygiene. Now, clearly, we were given a nice room. So the chief exec, I happened to let him know that we were coming, so I got a nice room. But I did it in a very subtle way, so it was all done beautifully. But clearly, the staff weren't told that the Chief Medical Officer and his missus were actually going to be there, or they just said, well, treat them like we treat everybody else. And this is a hospital that I understand does very well that's hand hygiene, but understand assessment of compliance is not a secret shopper thing. There's almost a neon light saying, auditors here today, for God's sake, wash your hands or use hand hygiene. So in this circumstance, over the 4 days that I observed my wife there in hospital, and I asked her at other times, we did the calculation. The maths wasn't hard. The hand hygiene was 0% over 4 days. Now, I do ask myself, what were you doing, Chris, just sitting there watching with your mouth open like watching a train wreck? Obviously didn't let them touch a wound in that circumstance. I can't say about the doctor because I didn't see the doctor. But what we've learnt, and there's some article just come out in the Lancet Infectious Diseases Journal, and just in the last month, where authors talk about hand hygiene being an acquired habit rather than a reasoned process, and that interventions designed to change behaviour are more effective if they target experiential thinking and socialisation factors. If I look at behavioural models for patient safety involvement, John Wakefield, produced from Queensland, at that stage headed up the Patient Safety Centre there, had a marvellous master's thesis, and Cliff and I had the benefit and were the opportunity to read that. And he talked about the likelihood of involvement of a range of clinicians to be undertaking patient safety involvement and why they may or may not do that. If you have a junior doctor, say, as a level 1, and you look at the odds ratio, if you like, for others to be involved. So the junior medical staff were the lowest, in fact, in a ratio of 1. The best were senior nurses, most likely to show patient safety involvement at 6 times more likely. Junior nurses, almost 4 times more likely. Senior medical staff, to my surprise, were 1.5 times more likely than junior doctors. Thought it might have been the other way around. What motivated junior doctors to exhibit patient safety behaviour? The behaviour of their peers, their own peers, not nurse peers or whatever, their own doctor peers at their level. A belief that there were system causes of errors and that they could be involved with doing something about that, and also that they were satisfied in their work, that they felt happy and comfortable in their work environment, they get involved. With senior doctors, peer behaviour again was the most important. Their own formed attitudes to patient safety and behaviour were important, and the belief that you could work in the system to prevent harm. You could do something there. But if they believed that error was a personal failing and not a system issue, then they were less likely to engage in patient safety behaviour, and that certainly was having an impact. Finally, I like saying finally a few times in a talk because it keeps the chair happy. There's a paper also just produced in the journal Psychology, Health and Medicine called Skating on Thin Ice, Consultant Surgeons' Contemporary Experience of Adverse Surgical Events. And they studied surgeons' perspective on how and why events occurred through a range of interviews about general and specific events. The findings included that pressures to work harder, faster and beyond capability within a blaming culture led to adverse events. But also there was an optimism bias from overconfidence and complacency amongst some surgeons, and also a completion bias, multiple pressures to finish an operation or a list. They also noted that consultants felt powerless and helpless to change their environment, their organisation and system problems, and that new communication and action channels were desirable. So this notion that while checklists did avert important problems, social, environmental, organisational and contributing factors were really important. And Bob Maudsley spoke about the complex environment. Truly, finally, I think it's important to leave a conference with a thought, a question and a comment. The thought is, with all these words today on professionalism, what are you going to do about all those words? How many do you remember? I'll tell you what I'll remember. Jeffrey Metz's comment about something to do and to live by, that notion of attitude, behaviour and compassion. So Jeffrey, I'd like to thank you for that. I have a question. What on earth, David Prideaux, was that ENT and lung disease sign doing amongst that clump of grasses? So if you could let me know that, that would be good. And finally, a comment, a bit of gratuitous advice. We've come to a summit today. It's a grand name. It wasn't a conference. It wasn't a symposium. It wasn't a colloquium. It invokes lofty aims, learned minds, and mind-moving outcomes. What's going to be the outcome? We've seen it. It's a statement. It might be a tripartite statement. But does that do justice to the output of a summit? I think what you must do is convert your statement to a geographically located declaration. Not the Hilton on the Park declaration, but the Melbourne declaration will come out from here and people will truly sit up and take notice. Thank you.